So it's a great pleasure to open the second part of today, and we're beginning with the Carolyn Biro lecture, which is a lecture that we established in 2002-2003 when we started this series of medical meetings. Carolyn Biro was the founder of the charity. I was very privileged to know her. When I was a research fellow, part of your initiation was to present at patient meetings and then to be interviewed by Caroline. Caroline would sort of suss you out over a period of 2 or 3 years. She'd see how well you presented. You'd then be invited for dinner. And that wasn't just to see whether you had good table manners, but it was to see whether you actually understood food. And if you understood food, you were 70% of the way there with Caroline. To get the remaining 30%, though, you had to show that you were different. Different in the sense that you cared. Because when she was first diagnosed with hypertrophic cardiomyopathy, the thing that she encountered was ignorance, sometimes not willful, sometimes completely willful. That people didn't want to know about this disease, that they mismanaged this disease. They didn't understand the impact on the individual and the family. And everything that the charity has done, and I hope that everything that those of us who learned from the charity and learned from the patients who are members of this charity have tried to do, is to raise the bar not only in the quality of care, but also in our understanding of what it's like to live with one of these diseases. Over the years, we've had a number of, I think, eminent speakers, and I'm very pleased to welcome Professor Merlini from Pavia to give this talk. For those of you who don't know, Professor Merlini is probably one of the world's authorities on amyloidosis. He originally trained in the University of Pavia, and I think developed his interest in monoclonal gammopathies working with Professor Waldenstrom, who I'm sure you've heard, in Lund, later in Columbia. And then when he returned to Pavia, he's established a national referral service, which is, I think now sees more than 2,000, maybe 3,000 patients. So he has a unique experience. And you'll have to forgive him, he's not a cardiologist. He's a hematologist and clinical chemist, actually, which is an interesting combination. We first met, I think, in Stresa. And it was one of those sort of post-meeting dinners where you're sitting next to someone, and he said, "What do you do?" He says, "I'm a hematologist." And he says, "What do you do?" I said, "I'm a cardiologist." And immediately we thought, "Oh my God, this is going to be a terrible evening." But actually it turned out to be a fascinating evening. And we found a huge overlap in interest and ambition. And since then, we've bumped into each other at various meetings. And I felt that he was an ideal speaker for this moment in time because amyloidosis is a very good example of a rare disease that we miss all the time. And even more importantly, now has a treatment. So for those of you in the audience who say, "Why should I bother looking for this stuff if there's no treatment?" Now there is. So it gives me enormous pleasure to invite Professor Merlini to talk about treatment frontiers in cardiac amyloidosis.
I'm really humbled by the honor of the Carolyn Biro lecture, and I'm extremely grateful to Professor Elliott for this great opportunity to discuss with you these challenging, but I believe treatable conditions. And in my talk, I will just discuss with you the advances that we have done in understanding, because understanding is closely linked to the progress that we have made in this disease. And I will briefly touch on the diagnostic approach, focusing more on novel drugs, and I will provide a few perspectives. So this group of diseases are caused by misfolded proteins. They are all rare conditions. And there are now 34 different proteins that they are completely unrelated, but they all converge into this highly ordered ultrastructure with a characteristic interstrand and intersheet distance as documented by X-ray diffractions. And this regular structure allows this dye to intercalate and provide this characteristic optical property that is diagnostic, as we have heard from the beautiful lecture by the pathologist, Professor Ashford, a few moments ago. There are at least 6 different proteins that can affect the heart significantly. And some of these are indeed acute conditions. So if you miss the diagnosis in this patient, you really compromise the survival of this patient because they are really rapidly progressing. Other forms, such as apolipoprotein 1, is rather benign. People could have a large amount of amyloid in their heart and the heart still function properly until the age of 80 or 90. In between, there is transthyretin, that is the topic, one of the topics of my presentation today. So the light chains, monoclonal light chains and transthyretin constitute now almost 80% of the patients that we see in Pavia. And for this reason, I will focus on these 2 conditions with you. Transthyretin is a transport protein. It's produced by homotetramer in the liver, and 95% in the liver, a little bit in the eye and the choroid plexus. These are important for the complication after certain treatment. We know now the monomer is 127 amino acids, and we know more than 100 mutations that can transform these proteins into an amyloid protein. And we know now that there is what we call this mechanoenzymatic mechanism that produces this protomer that is highly amyloidogenic. We will come back because it's relevant for the treatment. And we need to dissociate this tetramer in order to form the monomer that misfold. And this misfolded monomer then aggregates and targets several organs. The most interesting part is that a single mutation directs the transthyretin to a specific organ. So there are certain mutations which are almost exclusively affecting the heart, some other affecting the neuropathy, and as Claudio Rapezzi mentioned several times, there is a spectrum between these 2 conditions, with several patients with combined conditions. To make things even more complex for the cardiologist and for ourselves, male individuals after the age of 60 can develop amyloid deposit formed by the wild-type transthyretin, what was called a senile systemic amyloidosis. We call it now wild-type amyloidosis. This deposition can be massive, as you can see here, and we will come back on the significance of this. So we know an interesting finding is that we can find this protomer, this fragment, in tissue of patients only that are elderly with cardiac involvement, with few exceptions, throughout all the mutations. So we know that this fragment is important for targeting the heart. And why is this so? Well, it has been proposed by Professor Bellotti that the tetramer is first subjected to a proteolytic cleavage here by trypsin. And once you have this cleaved tetramer, this destabilizes the whole tetramer. And we think that the shear stress, particularly the squeezing of the heart, is contributing to this. And this 148 fragment now is highly amyloidogenic. And after this, a monomer is released. And this monomer then contributes with the fragment to the production of fibrils. And this is completely reproducible in vitro. So we have to take care of this, and we may explain why the heart is such a target organ. This is our patient population. You see the family history is present only in 40% of our patients. So do not disregard the diagnosis if you don't have a family history in these conditions, for several reasons. Most of the patients, in Italy we have more than 30 different mutations. It's the same all over the world. But you see, the vast majority, in 80% of the cases, we have both the heart and the nerve involved, and in 1/4 only the heart, prevalently the heart. So the heart is really what kills our patient. So there is a Taos registry. Claudio Rapezzi now is in the steering committee. If you have an early onset without heart involvement, the median survival is approximately 10 to 15 years. if you have a late onset with fragments and heart involvement, then the survival is bleak. Why is this so? Well, we believe that transthyretin mutant together with light chains can be directly cardiotoxic. So we investigated this in vitro. And indeed, the amyloid light chains compared to the control myeloma light chains and transthyretin, both the mutant and this particularly highly cardiotoxic mutant, can induce these abnormalities in the mitochondria. This stain is a marker of the potential, the membrane potential of mitochondria. And this results finally in reduced viability produced by the light chains and by transthyretin. So although transthyretin is produced, the damage is produced by the accumulation, there is also a toxic effect that varies between the different mutations. This translates in high production of this cardiobiomarker and NT-proBNP. It is particularly relevant for these two mutations that target the heart, and also in advanced phase of the wild type. But you see, it's not 100% sensitive, and we can miss some of these patients. Why do we care about this? Well, this is apparently considered to be a slowly progressing disease. It is actually a rather rapidly progressing disease. This is the neuropathy. We have most of the damage occurring in the first 2 years. So if we miss the diagnosis, we really compromise the quality of life in this patient. And for certain mutation, transthyretin mutation, the heart involvement can be as bad as for light chains amyloidosis with really reduced survival of few years. Early diagnosis is an unmet need. And we really miss some of these patients every day. And when should the cardiologist think about this condition, where time is life? Well, every time you have a thickened ventricular walls in the absence of hypertension, advanced atrioventricular block of unknown origin, and if this is combined, as Claudio Rapezzi discovered, with carpal tunnel syndrome, particularly if it's bilateral, you have to think about these conditions. Family history, but remember that 60% do not have it. If there is a neuropathic progression, you have some time to be very careful in looking for that. But again, this is a hint for this type of amyloidosis. Well, if you have vitreous opacity, that is diagnostic. You can make the diagnosis right away. Imaging is very important. As Perry said, I am a poor hematologist, so I don't dare to get into this. But here there is Christina Quart has done beautiful work on the strain Doppler imaging in these conditions. And again, the Bologna school showed that this bone seeker, DPD or HMDP or pyrophosphate in the state, accumulates specifically in the heart of transthyretin amyloidosis. And we can exploit this for diagnostic purposes. Well, we will hear after my presentation about MRI is open new windows in the diagnosis of this patient, but also in understanding the molecular mechanism of the disease. And in Pavia, we are exploring the use of this marker that is used for Alzheimer's disease because the amyloid structure is the same. And is a wonderful marker for early cardiac involvement. We need is an amyloid deposit. We need the biopsy, so the pathologist was right. So we rely on the diagnosis for tissue biopsies most of the time. The labial salivary glands are a good spot. In Pavia, we use a lot the abdominal fat, but it's not very sensitive in these conditions. The nerve, we never biopsy the nerve because it's patchy and it leaves a permanent disability, so we don't do it any longer. DNA analysis, of course, for the mutations, but once you have detected the amyloid, you have to type it. And in Pavia, we use mass spectrometry to do it as a routine method. If you don't type it, you can make a catastrophic mistakes in treatment, what we call titanic mistakes. We can avoid the biopsy actually now. This is a very recent work is a collaborative work from all over the world. So if you have a high uptake by the bone seeker, and you don't have a monoclonal spike or free light chain in the serum, you can go directly to this way, and you can make the diagnosis, you can do the genotyping, you can do the diagnosis of transthyretin amyloidosis even without biopsy. This is a new way to do it. So now we have the diagnosis, what we can do. We can do a lot now. We have so many treatments, because understanding the mechanism that I show you open the windows for new treatment. So we can do liver transplantation to remove the liver, what we call a surgical gene therapy. Or we can silence the gene now, and this is feasible now in the clinic. Or since we need to destabilize this tetramer, we can stabilize it with small molecule, such as tafamidis and diflunisal. These are in the clinical setting. All what is in red is already in the clinical use. Or we can inhibit the aggregation, or we can direct this aggregate off pathway with epigallocatechin gallate. We can address the oxidative stress inflammation with anti-cytokines, and we can also target the amyloid fibrils with anti-SAP therapy or with this combination. We will talk about that. Liver transplantation, unfortunately, for patients with heart involvement, is not really the final answer, unless you do it very quickly. You see, if you have early patient with early onset without heart involvement, the outlook is excellent. For the other patient with heart involvement, the outlook is. And you can see the progression of cardiac deposit, even if you do the liver transplant, because the wild-type transthyretin keep accumulating in the heart. We can now silence the gene using these antisense oligonucleotides. They can degrade through this enzyme RNase H-mediated degradation. And we can significantly depress the synthesis of the protein with this approach. A phase 3 trial was announced for cardiomyopathy, but now is under scrutiny. Another approach to silence the gene is using the small interfering RNAs. This has been reported. This is extremely effective. We have dozens of patients in these trials now. And we can do it. Now there is a phase 3 trial endeavor that is subcutaneous in patients with TTR cardiomyopathy. So we have trials ongoing, and please refer your patient to the centers to be included in these trials. Tafamidis, we have used it in patients with cardiac involvement. What we can say is that it seems to slow down the progression of the cardiomyopathy. You see there is a fraction of progressing patients according to NT-proBNP. The same result using NT-proBNP and troponin together with the walking test has been reported by Morer at Columbia. It is stabilizing the conditions, more or less. It's not a very effective treatment. Why is not so? Because we know that to achieve the full protection, we need to occupy both the site of thyroxine binding in the molecule. And there is a negative cooperativity. So once you have occupied one side, you need to have a higher concentration of the drug. So from this observation, we derive the rationale for a new treatment. And Professor Perry is the steering committee of this trial. So we have used the same drug, but higher dose, because most likely the fact that the drug was not very effective was due to underdosage of the drug. We will see the trial has concluded now, has completed the enrollment, and we should have the data by the end of this year. Diflunisal is another small molecule that we have tried in Pavia, in patients with transthyretin amyloidosis. It's a small trial, phase 1-2 trial, 30 patients. It's rather well tolerated. It stabilizes both the echo findings and troponin and NT-proBNP during the period of observation. In Pavia, we also reported several years ago that a small molecule, iododoxorubicin, can really favor the reabsorption of the amyloid deposit. And we reported it in a patient with AL amyloidosis, before and after the treatment. This is, however, toxic, is a chemotherapy agent. So we reasoned that the same polycyclic structure, the tetracyclic structure, is present in doxycycline. And the in vitro data reported effectiveness of this small compound that is readily available. It's non-toxic, it's a common antibiotics. So I obtained orphan drug designation from EMA for this drug. So we have just concluded our first study in this patient. So 40 patients treated for 12 months is very well tolerated with doxycycline plus this potent antioxidant. And then there was 6 months washout. And there were responses in our patient. During the treatment, there was a stability of the NT-proBNP. And then during the washout, there was a worsening in almost this patient. This was captured by the global longitudinal strain. There was an improvement during treatment and followed by worsening. This is easily performed, so this can be done in every center. Another small molecule, as you know, is this green tea extract, the epicalogatekin gallate, is another antioxidant. This is the German study performed in Heidelberg. Again, during the treatment for 12 months, there was stability in the cardiac marker in the clinical setting. There is now a new approach trying to remove the amyloid deposit, and this can be done using antibodies. Antibodies that recognize this epitope that is present only in the misfolded transthyretin. So it does not recognize the wild-type transthyretin. These are a group of antibodies. And it can stain perfectly the amyloid deposit, but also these early aggregates. And this antibody is going to start to be used in a clinical trial very soon. So for patients with transthyretin, we have several options now. So we have different drugs available for our patients. What about AL amyloidosis? Well, we know that there is a small clone producing these misfolded light chains. Now we have the crystal structure of these light chains, because we would like to see if we can stabilize this light chain as we do for transthyretin. They form amyloid with this concurrence of this pentraxin. They form the fibrils, but we believe they are directly cardiotoxic as well, because this is, and the heart is the main organ. 76% of our patients do have significant heart involvement. The important point is that the disease can be rapidly progressing. So why do we say so? Well, this is the same patient, 70-year-old. She was treated successfully with this chemotherapy with the prompt elimination of the free light chains. As you can see, in a matter of few months, the amyloid deposit is still there, but there was an impressive clinical improvement and a marked reduction of the cardiobiomarkers. The patient is alive, although she started in stage 3, so in rather bad conditions. So we went on the clinical, from the clinical observation from the clinical side to the bench side, and together with our friend at Harvard, we found that the amyloid light chains activate this MAP kinase, producing oxidative stress in the cardiomyocyte with cellular dysfunction and cell death. Very interesting, this same pathway is important, is controlling the synthesis of NT-proBNP. So this is a really extremely powerful marker in AL amyloidosis because it's reflecting the pathology of these conditions. And this explains why we can use these inhibitors to block both the cardiotoxicity and the BNP concentration. This marker is a wonderful marker for diagnosis. It detects 100% of our patients. It's not specific, but it's extremely sensitive. We can use it also to stratify the risk for this patient. If you have very high concentration of NT-proBNP at present time, we cannot help this patient. And we can use it also to evaluate the response to therapy. If you reduce the concentration of NT-proBNP by 30%, that is the case here, you change completely the biology of this condition and the natural history. So this marker is a powerful tool for the cardiologist to follow this patient, together with all your investigation system. Indeed, the cardiotoxic light chains can induce mitochondrial, they really get into the mitochondria. These are a confocal microscopy showing that the light chains interact with mitochondrial proteins and with critical enzyme in the beta oxidation pathway. So what the light chains does is that it inhibits the production of ATP by the cardiomyocyte acutely. So it transforms a normal functioning heart in a failing heart biochemically by depriving the heart of energy. And the mitochondrial damage is devastating in this condition. You can compare these are transplanted heart from patients with amyloidosis compared to the donor mitochondria. The heart is really, so I was very pleased when Perry asked me to talk about the heart, because it's really the heart of our interest. Because all of our patients die because of heart. If you don't have heart involvement, you don't die of amyloidosis. And 30% of our patients die at 6 months, 94% of heart failure, practically all of them. So the heart is the big killer of all of our patients. We need to make an early diagnosis. Unfortunately, when the patient comes to you, sometimes it's too late. So we have to anticipate this during these biomarkers. So we propose when you have a patient with a monoclonal gammopathy, you have to follow this patient using NT-proBNP and checking for renal damage. If you do this, you will not miss any of these patients, and you can make the diagnosis in time to be treated effectively. It is true, amyloid is a great imitator. It can mimic many different conditions. Fatigue can be impressive in these patients. If you see these findings, of course, you can make the diagnosis right away. There is no other condition. You can make the diagnosis on the tube right away. There is no other way that can give you this. We can discuss why. But when you see this, of course, the diagnosis is done. Particularly when you have heart failure with preserved ejection fraction, the characteristic of this condition. But this is too late. So please use the cardiobiomarkers. We can assess the risk using a marker of cardiac dysfunction and cardiac damage. So if you have both of them increase, you have a very poor outcome. And this subgroup can be further stratified in the stage 3 according to the concentration of NT-proBNP. This is very important because at present time we don't have a valuable treatment for this patient population. But we can really certainly treat very well these patients. And so we have two markers, the amount of amyloid damage to the heart and the amount of toxic light chains. So these are the two prognostic determinants. Treatment is aimed at anticipating the damage and to obtain an organ response. So we have to stop the production of these light chains in order to produce cardiac improvement. We know that it's not enough to achieve only a hematological response. You need to have a cardiac improvement. We have several drugs now available. This has been developed during the last decades. You see how many of them we have available. And we use them and stratify the patient according to the cardiobiomarkers again. So if you have NT-proBNP less than 5,000, you can treat this patient with high-dose chemotherapy. The cardiac response is 1/3. If this patient responds well, they can be considered almost cured. The survival of patients achieving complete response is not reached after 10 years. So we can really cure this patient if we intervene in time. But this is really an unmet need. Patients who present with advanced cardiac damage. We don't have really an effective treatment for this patient. And these are 1/5 of the patients we see, 20%. So we can use heart transplantation in patients with stage 3B, but they need to have no other cardiac amyloid involvement. This is extremely rare. We can use the cardiac transplant and then stem cell transplantation. We have done several of these patients with good outcome. Left ventricular assist device has been a disaster since now. Now that we can select this patient better, the outcome seems to be better. And the defibrillator needs to be applied just to very specific patients. The main problem is that we are really disheartened by this because these patients for heart transplantation, they die very quickly in the waiting list. You see the survival of our patients. We don't have time. So we have to think about something else. As I told you, chemotherapy, and we have tried many different regimens. This is the outcome. It's just few weeks of survival. So we cannot really help these patients nowadays because we have been diagnosed too late. Sorry. So we need more research. Well, we know that the light chains are cardiotoxic also in zebrafish. If we inject 2 nanoliters of light chains, we have a quick death of this fish. And if we use a MAP kinase inhibitor that is available now in the clinic, we can rescue this survival. We have used also this model. This is a C. elegans model. It has a pumping pharynx that is similar to the heart. If you expose this to the toxic light chains purified from patients with heart involvement, you have an immediate reduction of the pumping rate. And this is due to the fact that there is a massive oxidative stress in this small system, resulting in devastating mitochondrial damage. And you can inhibit this using doxycycline. So this observation was at the heart of this finding from the investigators here at the National Amyloid Center in London, led by Professor Pepys. So they treated patients with doxycycline plus chemotherapy. And you see patients treated with doxycycline in stage 2-3 had a much better survival than patients who were treated only with chemotherapy. This was not very helpful for stage 3B, but for stage 3A it seems to be extremely helpful. The same group has developed this new approach. They deplete SAP using these small palindromic molecules, and then they use antibodies to promote the reabsorption of the amyloid deposit in the liver, the spleen, and the heart, hopefully. And they have reported last year that with this approach, you can accelerate the removal of the amyloid deposit in patients. And this was a single dose, and if you continue to administer this, you can achieve a significant reduction of the amyloid load. Similarly, another company, Prothena company, has developed this new anti-amyloid approach, obtaining a significant improvement in NT-proBNP and in renal function. A phase 3 study is going on now and is open for frontline patients. So please refer your patient because we have several new treatments available. So I'm concluding now. This is what is occurring in L-amyloidosis. We have several very effective agents to get rid of the clone very quickly. And now we think that we can be successful in more than 70% of the patients to get rid of the clone with all these new drugs. We can even silence specifically the clone, or you could activate the quality control. But we are working hard now on this light chain stabilizer. Professor Eisenberg has recently reported that this is feasible. So although they are very diverse from each other, they conserve a specific part in the molecule that can be druggable. We can counteract the toxicity using these drugs, and we can restore autophagy that help in removing the damaged mitochondria. We can also attack the amyloid deposit. So the whole aim is to improve, to rescue the heart function. So indeed, the heart function is the core of all our interest. If we can recover the heart function, we save the life of this patient, but it is a must. So we have done really important progresses in this disease. This is throughout the years. Now, this is the data from here in London. These are the data from Pavia. We expect to help 60 to 70% of these patients, and probably to cure them. What has not changed in 30 years is the first part of the curve, the slope. These are patients who are diagnosed too late. So I hope that one of the main messages of my talk is that you have to think about this disease, and you have to refer it very quickly to an expert hematologist, because if you treat it in time, you can really save this patient. So it's really a new era, as Professor Aurelio said, in this disease. We have plenty of opportunity. We can make the diagnosis earlier. We have new drugs, and the therapeutic armamentarium is continually expanding. We have to combine these agents, and we will learn how to do it in the best way. To do this, we need to collaborate internationally. So in Pavia, we have this network. We've just met in Bologna. Claudio Rapezzi was there with us a few days ago. So we have this national group that is full of enthusiastic people, and we collaborate. We share the protocol, but we do also it at European scale to run trials. This is a trial that we just concluded. And none of this could be possible if there will not be enthusiastic and hardworking people such as Giovanni Palladini, Laura Obicin, the whole my team in Pavia. But international collaboration are as important as well. And finally, I would like to thank you again for this great honor and opportunity.